السلام عليكم ورحمة الله وبركاته. معاكم محدثكم حاتم نجار، أنا المدير التنفيذي للجمعية العلمية السعودية للهندسة الطبية. أرحب بالجميع. قبل ما نبدأ الويبينار تبع اليوم بس في تو announcement أو إعلانين حابين نشارككم فيها قبل ما نبدأ. الإعلان الأول زي ما أنتم شايفين في الشاشة، حتكون إن شاء الله غدا الخميس 13 ديسمبر من الساعة 6 مساء إلى الساعة 9 مساء في جدة وفي الرياض في نفس الوقت. حتكون انتخابات مجلس الإدارة الجمعية لدورتها الرابعة، فنتمنى من الجميع سواء الأعضاء أو غير الأعضاء أن يحضروا ويشاركونا هذا الاجتماع المهم. الأعضاء بإمكانهم التصويت لمجلس الإدارة الجديد. طبعا جميع مجلس الإدارة المرشحين الجدد موجودة معلوماتهم في هذا الهاشتاج في تويتر، بالإضافة أنه برضو موجودة جميع المعلومات في الموقع حق الجمعية في برنامج المرشحين وأسمائهم وبرامجهم وأهدافهم. الاناونسمنت الثاني والإعلان الثاني، حبينا نذكركم أنه باقي فعاليتين قائمة خلال السنة هذه. الفعالية حتكون الأربعاء القادم بحول الله، ويبينار الأخير اللي حيكون في السنة هذه ويبينار الجهات ذات العلاقة بالهندسة الطبية في المملكة وتعريفهم واهدافهم وايش الفروقات اللي بينهم، هذا مهم جدا لكثير من الناس. الاعلان الثاني او الاكتيفيتي الثالثه اللي موجوده اللي هو برنامج مقدم من شركه لينكد ان ليرنينج لمده اشتراك لمده 12 شهر بقيمه مخفضه مقدمه للجمعيه واعضائها ومتابعينها، فبالامكان برضو تشاركوا فيها وتشوفوا تفاصيلها في موقع الجمعيه. يعطيكم الف عافيه. طبعا حنكون دحين جاهزين. We will start now our webinar of today, which is belong to ECG Archiving and Management System. Today we will have two speakers. First speaker, he will be Dr. Naeem Al-Shuaibi. Dr. Naeem Al-Shuaibi, he's the cardiac electrophysiology consultant and head of adult cardiac department at King Abdulaziz University in Jeddah. Then we will have Mr. Thomas Lutz. He's the Director of Business Development for Europe, Middle East, and Africa at Epiphany Healthcare Company. So welcome both the speakers. I will convert now to Dr. Naeem Al-Shuaibi to be as a presenter for this webinar. Dr. Naeem, I will unmute you now, and I will give you the control for that presentation.
Thanks, Fatih, for having me. Hi, everyone. Very interesting to talk about ECG for non-medical professionals. So I'll try to make it as interactive as possible, as joinable as possible. And I'll make the language.
دكتور نعيم، في تشويش في الصوت تبعك، الصوت ما هو واضح. لا، الصوت ابدا ما هو واضح، مشوش جدا. It's not clear at all.
Can you give me just a second?
We cannot hear you. إذا أنت حاط سماعة ممكن تشيلها وترى راح يكون صوتك واضح عن طريق اللابتوب دايركتلي إذا حب. Yeah.
How is it now?
Yeah, ممتاز.
All right.
Okay.
So let's keep it that way then.
Okay. So I send you that to be your to be the presenter.
Okay. Yeah, I got it. So okay, can we start?
Yeah.
Yeah.
Please go ahead.
Yeah. So hi everyone. Sorry for this voice thing, but I think now as I heard from Hatem, everything looking good. So let's go back to the presentation. It's very interesting to talk about ECG for non-medical or non-healthcare provider, but I'll try to make it as joinable as possible. And from my medical point of view, what we would like to have and what we have all about the ECG data management and archiving system, how does that help the medical field and getting more of patients help? So I have no disclosure to this talk. Let me engage this.
Yeah, please. We're still not, your screen not clear now.
What about now? This is better.
الصوت اوكي بس الشاشة حقتك ما طلعت، ما ظهرت لسه.
I don't know. It should be in a presentation mode.
اوكي. في share screen بوتون اللي هي علامة الشاشة، تحتاج تعمل لها كليك تصير خضراء حتى تضغط. Yes, now it is. We can see your screen.
All right.
Yeah.
So
ممتاز.
let's go back to the presentation. So again, I'm going to talk about ECG data management and archiving system from the medical point of view. This is my disclosure. There's no disclosures for this kind of presentation. So I'll cover a couple of things. What is the ECG meaning? And I'll give you a couple of examples of disease recognition and how is the disease management or ECG management solution can help us from the medical point of view. So basically, the ECG is very simple tool. It's meant to, if you have any muscle activities, it just recognizes the muscle activities and change this into electrocardiogram, which is basically activity of the muscle. This is why when we do an ECG for a patient, we'll ask them not to move. Why? Because the only muscle that you cannot control, human being cannot control, is the heart muscle. So if you cancel all the muscle, the voluntary muscle, then the only one remaining is the heart. Any electrical activities at that time, so that's represent actual heart activities. And this is as simple as this, as an ECG tool. Then we have something we call it a standard ECG. What a standard ECG? It's basically it's something to recognize ECG easily. We have a standard form of ECG. Basically, it has like a 12 files, and we put it in a certain pattern. Why? Because it's easy for me to read the ECG. It would take me like 3 seconds to read just only one ECG. Why? Because there is a pattern recognition. If this let's say example, this is lead 2. If you go and read ECG in the States, in Canada, in US, in Europe, in Saudi, it will be in the same way of recognition. It will help the physician spot on diagnosis very quick. If each country make their own pattern recognition, then you will find lead 1 here, then the other country is here, the other country is there, then we'll have a problem of understanding ECG. By this, what we call it, how's the ECG look like, or the standard ECG. Believe it or not, this was the first ECG machine. This was in 1903. This is William Anhoven, who's the Dutch scientist, who's the first describer of ECG machine. He put his foot in the water. Why? Because the water is a good conductor system. It can get easy electrical activities. And by inventing this machine, he got the Nobel Prize in 1924. But now in 2018, we do not use this machine anymore. We became now talking about Apple Watch. It's a simple watch, can give you the same pattern recognition of ECG. This is how science evolution go with the ECG, from a very big machine to a simple machine that can give you the same result and similar answer. When we do an ECG, we put a lot of what we call it electrogram. Basically, we put a lot of Dutch here, one here, and one there. And each one of them, it has a certain pattern. So what does that mean? So it means if I brought 1 million normal subject, normal human being, and if I did the same pattern, I'm going to get the same result every time, unless this subject has a disease. If we know the normal, and if there is any change in the pattern of normal, then this is the way to diagnose diseases. It's the same thing. We do not just put it in the leg and the hand, we put it as well in the chest. And again, each one of them has a different shape. This is again in normal population. If there is any shift in normal pattern, then at that time it will be easy to spot on any diseases. This is an example of the beauty of a heart being. This is what we call, the heart has 4 chambers. 2 upper one, 2 lower one, and each one of them, it has its own electrical conduction system. And we can see it easily in ECG by different waveform. Each one of those waveform represent an area in the heart muscle with a different depolarization. Because always depolarization starts here, what we call it from the right atrium, and that's give us a pattern, what we call it a P wave in the ECG. Then the signals go down to the ventricle, which is the lower chamber. When that's activated, it gives us a bigger signal, what we call it a QRS signal. This is the normal behavior of a normal heartbeat. So let's skip this for sake of time. So now we know how to record ECG. So how to put this in a context? In an easy, simple way. Let's say, how do I recognize the heart rate? It's by simple concept. Distance equal velocity times time. By controlling the velocity, and controlling the distance, and we know the speed, then at that time we're able to get the time. This is how to recognize the heart rate. So if I know the distance here, and I know the distance, how much times I need to travel, then it's easy to get the heart rate. And this is what we talked about at the beginning about standardization. If I have a standard, then everything meaning something. If I change the standard, then we have a lot of signal that we don't know what does that mean. Let me show you an example. This is an electrogram of a normal heart. This is electrogram of the same patient, and this is electrogram of the same patient. Only by changing the standard, what does that mean? How much I want to see. If I reduce the voltage, I will see a less activity of this. If I increase the voltage, then I will see a lot of voltage of this. So if someone of my nurse or my technician change the voltage criterion, then easily if I see this by mistake, I also, oh, there is a disease. This patient has enlarged heart. In reality, he has nothing. Only I said that because someone has changed the practice, had changed the routine, had changed the standard. So this is why it's very important to read, before reading ECG, always as a safe physician, we always go and check in the standard to make sure this is in a normal pattern of a standardization. Then what I ever see, it means something to me. This is an example of a patient. Patient A, it's again patient A. This is, let's say, call it Ahmed, and this is ECG of the same patient Ahmed in the same time. And the only change that the technician has changed the standard. Here's standard of 10, change it to standard of 20. What happened? Look at this signal. This is a normal, now it became bigger. This is normal, now it became bigger. So if I see only this ECG without looking into the standard, then I will call patient has a diseases by mistake. And this is why it's very important to look at the ECG data management. It's not about I need an expert cardiologist to read the ECG, but we need to archive it in a way that everything, every tools in all those numbers, it does matter to me as a physician. So let's go now, after give you a couple of examples. If you go into 2018 era of medicine, if you ask me, maybe I'm a little bit biased, what is the best medicine tool that we use to diagnose it? Maybe I'll say ECG. Why? It is very cheap. There is no clinic, there is no hospital that doesn't have it because it's cheap, and it gives you a lot of answer. We cannot save patient life without ECG. Even if you open a cath lab and you invest in 10 million reals in this cath lab and you didn't have an ECG, you cannot function as a unit. So this is the ECG, it's the cornerstone. If you're gonna go and build a building, you cannot discuss with me what's gonna happen in the 6th floor and you don't have the fundamental of the 1st floor. So this is ECG, it's a basic fundamental of a healthcare hospital. You cannot have an emergency department without ECG. Just it can't. Why? Because it's diagnosed a lot of things. We save a lot of life only because of the ECG. When you have a patient with heart attack, oh, I will say this patient needs to go to the cath lab now to open his artery. And some patients, when I do ECG, I'll say, no, he can wait tomorrow. And some people, they will say, no, he can wait to a month from now. How I can make this decision? I make this decision based on ECG. As you see here, we can diagnose a lot of diseases only by this simple tool that's take only 1 minute to do and print. This is an example of artery of the heart. This is, let's say, we call it the right coronary artery. If I clog this and I block it, then we call it a heart attack. How do I diagnose this? Trust me, it's not by the imaging, it's not by the CT scan, it's not by the MRI, it's not by going to send the patient to the coronary angiogram suite, it's only by ECG. It can give you the spot in diagnosis within a second, and based on that, you can further risk stratify the patient. And if, with this slide, I need you to keep a very good attention. This is what we call it a stage of a heart attack. So how do we know the stages of heart attack? It's very simple. We diagnose the patient with a heart attack, and then based on a study, based on research, we look back in their ECG recorded. And what we found, on 100 patients who had a heart attack, the first ECG they have something like this, something we call it a T wave, a big T wave. All right. And then after 5-10 minutes, their ECG changes to this pattern. Then the ECG changes to this pattern. How in medicine we are recognizing this now? This is only simply because of the ECG data management. We are now diagnosed patients with heart attack. We diagnosed millions of patients with heart attack. And then we went back to their ECG and we found something in common, which is this ECG phenomenon. And by finding this something in common among all those patients with heart attack, and now we say, okay, if I have a patient with this pattern, I will say, oh, he's in a very early stage of heart attack. But if I see ECG like that, I will say he's in a late stage of heart attack. And again, how do you go and check with this? This is only because we keep record of ECG. If the hospital do ECG and the physician read the ECG and took it to the garbage, then nobody can look back and get something for investigation, something, a pattern recognition, something to be a research tool. So we have to have this ECG recording. In all days, we have to keep it in a paper. Most of the hospital nowadays, even here in Saudi Arabia, we are now moving into a digital platform. It's very hard to find a 12-lead ECG in a paper. We now transfer this all into electronic system. But it is very important to keep those records. It's only because of to see where stages, what is the future is going to have with those diseases. Maybe we're gonna invent a new way to look into the ECG. Without having ECG in our hand and keep it in a record, then it will be very hard for us to bring information and knowledge. Let me show you this in another example. This is one of my patients who came to the clinic, who basically, they say, he's a 50-year-old, he came with his daughter, and he has a recurrent loss of consciousness. This is his presentation. I did an ECG in the clinic, and it was basically a normal ECG. So if I see this ECG, I will say it's normal. Let's see, do a couple of investigation. Then a minute later, his daughter said, oh, I have another ECG with me. And I asked her, please show it to me. And she showed me this kind of ECG. This is the ECG, same, just this is one lead or one eye of the same patient, and it showed me this disease. When I saw this, I know what is the diagnosis, and I know this patient that needs pacemaker right now. What does that mean? The diseases in medicine or diseases in cardiology that I can catch in ECG that most of the time does not stay there 24 hours. It comes and goes. Without having an archiving system, without having a tool to keep a record of those, this young guy, he might go and drop dead at home. Why? Because I just did the ECG at the hospital, it was fine. But at one point, he had another ECG which was not fine. This is why it's very important to keep a record of those patients. Let me skip this. I'll give you an example of another patient. This is a pregnant mother. She's safe, she's young, she's healthy, never had a heart problem. She went to the hospital only to give a delivery. And in the morning, she wake up at 6 o'clock and basically she's brushing her teeth. And she was attached to the ECG monitor. And once she started to have this brushing teeth, and remember when I say to get an ECG, you have to be calm, not to move. Why? Because the ECG meant to record only the electrical activities of any muscle, which is basically what you are interested in is the heart muscle. This poor mom started to have brushing her teeth. All the muscles are working, and now get you a lot of electrical activities. The treating physician, they call a code blue. Code blue, that there is an emergency in the hospital. Everyone rushing to this poor mom because of the ECG finding because she's just brushing her teeth. If no one can, if someone who's not recording this, or someone has recorded this and they give her the wrong management, or and put the mom in the bed and they give her wrong medication for arrhythmia, then it will be a far-fetched for this lady. Once we saw this ECG, we'll say, oh, this is just an artifact. But how do you reach this diagnosis? Someone has kept this ECG to be read by an expert. As you see here, there's someone who wrote ventricular tachycardia. This is a bad form of a heart rhythm. A heart rhythm can kill a patient, but which is basically is not the right diagnosis. Why? Because if someone expert in reading ECG will say this is just an artifact, please leave this mom alone. This is another example. This is basically a young guy. His brother came to my clinic. Basically, his brother died at the age of 17. And you know, when someone who died young, it's very catastrophic for the whole family member. This is the ECG of his brother, actually. And when I see this ECG, I'll say, yeah, there is minor changes. It's not really significant. But this poor guy, before he died, he had this ECG in other hospital, which we fighted to get it. And this is the same ECG before he died, like 6 months before. Because this guy, he was passing out, did ECG, and that's what we call it. It's a specific disease in medicine. We call it Brugada Syndrome, which basically has no symptoms other than sudden cardiac arrest or sudden cardiac death. By having this ECG now in the index patient who died already, now we're able to screen the family. We can tell the family, you know what, this disease can be genetic. We have to go for screening, and maybe the brother and sister, maybe they will be at risk of sudden death as well. So this is why we have a family screening program. With those family, they are a member of 7. We discovered 4 of them, they have the same disease. And we implanted for them a defibrillator just to prevent sudden death in the rest of the family. And again, this is the beauty of ECG. You can get the full story, you can help the patient, but if you have the full version of the story, if you are able to get ECG data management in one system, it's easy for me as a physician to look for the ECG now, look for the ECG in the past, because as I mentioned, the ECG can have a temporal variation. What I can see it now, I cannot see it. This is another example. This is a young patient who's athlete, who's very healthy, healthier than me. He's a 20-year-old who's running and playing soccer, and he's very healthy. If I see this ECG in a young individual, he's not athlete, I will call this as an abnormal ECG for sure. But research has taught us, if we get 1,000 of athletes and they're totally healthy, they do a lot of investigation, and we're pretty much sure that they are healthy. And what we found in them, as a special pattern in their ECG that's look funny, but for them as an athlete, it's not funny anymore. This is just an easy ECG, normal ECG for them. No need to be scared, no need to quit sport, no need to do anything. Why? Because this is a pattern of a normal ECG in athletes. So how we can reach this stage of knowledge is by having ECG, by having all those 1,000 of athletes who went to do the sport and someone has done ECG with them, and archive it and kept it in a good place, then we can make a pattern recognition out of those ECG. This is just an example. This is let's say this is one panel, and this is another panel. This is all for athlete's heart. All those people, maybe if you go look, maybe they have the same pattern. Even this is the same pattern, but there's a minor change that's just changed the whole story. The people are here, they are at low risk. The athletes at this level or this stage or this level of changes, they're at higher risk. How do I know this? This is not a magic. This is basically, we did an echo, we did an MRI of the heart, we found the pathology. Once we found the pathology, then we go back and look at the ECG archived in the system. And based on that ECG, if we are able to find a pattern in those ECG, then we're able to get a diagnosis. Then if I have an athletes came to my clinic and I found ECG and I found it one of those, I will say, you're good, you're safe, go and practice and you'll be fine. But if I found any of those changes, then I'll say, no, you have to be careful. This is a disease, need to be treated, and maybe you have to quit doing a sport. So let me conclude with this. ECG can tell the whole story, but if you have the full version, having one ECG in a clinic is not enough for one patient. But if we have multiple ECG that accomplished and stored at a good level, that can help me a lot in completing the story. And again, ECG finding, unfortunately, is not constant in most of the time. It has a lot of temporal variation. It changes patient to patient, changes hour to hour. This is why it's very good to keep record of those ECG. And again, keeping the ECG record is essential for me to diagnose. And again, it's very important for future discoveries. I think with this, I will conclude my presentation, and I'm happy to take any question.
Thank you, Dr. Naeem, for this interesting presentation. In order to send your questions for the audience, please go to the tab of questions, and you can type any questions you wish Dr. Naeem to answer, and he will read it and he will answer it.
I'm just waiting for any question to show up. I don't have any so far. So someone here is asking, I get a question there. Someone who said now this became a medical question. Why it's important for a pregnant lady to get an ECG? Really, 99% of pregnant lady no need to do an ECG for them, but that was some extra caution of that particular hospital. So another question is is archiving ECG occurring already in different health stores? Yes, my answer is yes. And I'll give you an example. In our university hospital, King Abdulaziz University Hospital, yes, we do that now. We started this year to have archiving all the ECG because it's a very important matter. There is another question. They said, did you mention the complexity? I think maybe this question from a person who is in medical field. So this is just my presentation was to keep it open for everyone to understand. I'm not going to go into detail into how to read ECGs. Someone will say, what is the disadvantage of ECG? I will say disadvantage of ECG is 0. The disadvantage sometimes for whom is reading the ECG. The ECG has no disadvantage. It's very cheap. It costs 5 riyals. It has a lot of answers. Give you a lot of life saving. This is the question. I have more. If you can allow me, I'll just take another 5 minutes for a question. For the athletes, how to know that I need to make ECG? So there is a definition for athletes. So if you're going to go and play soccer with your friend every weekend, you're not an athlete. So athletes who are someone who's making a job, who's making the money out of his sport. Those people, by all the guidelines, American, Canadian, European guidelines, they need to have at least ECG or echocardiogram and to see a cardiologist before go and practice their competitive sports. Let me see if you have more questions. For how many months for the ECG has to archive? I will answer this in a funny way. As example, it will say I have a lot of 100 riyals in my pocket at home. How much should I keep them? You should keep them all. So you should keep all the ECG, because everyone at one point of stage, it will help us. If it did not help this patient by himself, maybe it will help us for future research. Again, I'm not going to answer any technical question how to read ECG, so I'll just keep skipping and reading a couple of questions. Is it an electronic form? Yeah, we have the ECG. We just do the ECG by the machine, and we transfer them by Wi-Fi or Bluetooth to the system. When ECG is mostly used, I do ECG for, if you're gonna say, you come to my clinic and you say hi, you're gonna get an ECG with me. So I'll do ECG for everyone who's coming to the cardiology clinic or heart clinic. I'll just keep reading the question. I have lots of them. Some of them are technical questions. Some of them are medical questions, how to diagnose diseases. So I'm sorry, I'm gonna skip this because this is not to be for this presentation. I think yes. The question again, do you have an archive system ECG? Yes, we do. Can you diagnose any other diseases? Trust me, I can diagnose more than 300 diseases in medicine only by ECG. Sorry, and just keep reading. We have lots of questions, mashallah. What ECG stand for? Electrocardiogram. I think, Adam, I think I'm done here. Most of the question now that's arrived, it's all about technical reading of ECG. How do I read ECG? How to diagnose diseases? This is by itself, it's an ECG lecture, but with this presentation, it's meant only to help understand why we do ECG, what is the importance of archiving ECG. I think with this I conclude, if you allow me.
Yeah, thank you very much, Dr. Naeem, for first part, the importance of the ECG and the archiving system as a consultant of cardiology. Now we will shift to the second part with Mr. Thomas Lutz, who will explain more about the technical and the IT part of ECG archiving and management system. Thank you again, Dr. Naeem, and we will move now to Mr. Thomas.
My pleasure. Thanks for having me. Bye-bye.
Thank you. Bye-bye. Okay, Mr. Thomas, do you hear us?
I can hear you. Can you hear me?
Yes, and we can see your screen now, and you can start, please, your presentation.
And my screen is currently empty, right?
Yes.
Now you should see my first slide where I basically just have a picture of myself mainly. So yeah, thank you, Dr. Naeem. Was an excellent introduction, which makes it much easier for me. So I can go through a lot of details more quicker than I expected to do. So my name is Thomas Lutz, and as you can see, looking at my picture, especially if you focus on my hair, which was once upon a time really honestly dark brown. So you can believe me looking at that picture that I'm already 34 years in the healthcare business, and the majority of it was in the cardiology area. So I started 84 working for HP, which then transitioned into Agilent Technologies for a short period of time and then was acquired by Philips. There I was responsible as well for ECG data management and the whole range of diagnostic cardiography products. Total more than 20 years in that company. And then it was followed by nearly 6 years working for General Electric, also in EMEA, and EMEA stands for Europe, Middle East, and Africa, responsibility for ECG management and hospital cardiographs. And since 2012, I'm in my current position working for Epiphany Healthcare, which is a US company, and that company is acting as a global provider for ECG data management solutions. So that was in a nutshell quickly the introduction. So let's jump into the business. And what I learned over all those years, and what you as well learned just recently now with the presentation of Dr. Naim, and think also about the fact that more than 30% of the early deaths or sudden death is going back to cardiovascular diseases. And the ECG, as nicely pointed out in the previous presentation, is a major tool in early detection and diagnosis of a lot of those diseases. And it acts as well as a triage tool then for all the other diagnostic tools. And it's non-invasive, it's cheap, easy to apply, and what was nicely pointed out, it's always important as well to have the previous ECGs for that patient. So, and if you look at a paper-based scenario, which is still the case in some hospitals, and also, of course, a case if there is a bad implementation of a digital solution, then you have maybe similar problems. And those problems include that because the ECG, and that was nicely described, so thank you for that again, Dr. Naim, the ECG of a patient can change within minutes. And so it's important to have access to the previous studies for proper diagnosis. And so no access to the previous ECG results basically may result in unnecessary hospitalization of a patient. In the case of, in the best case, looking at an, like in the example of a sports guide of an athlete, because what's normal for him, what's abnormal for a different one might be absolutely normal for that guy. And late overreading, of course, as well delays diagnosis and decreases the patient risk, because every minute counts when in certain diseases. So you want to have that patient quickly in the cath lab and not waiting for a long time because nobody looked at the ECG. So with all of that, of course, the ECG data management helps, and it's not just for the ECG as well. Such a system, if you put it in place, can help as well with all the other diagnostic test results, because you have complex workflow processes in a hospital. That means you want to have different workflows in the different departments or for the different physicians. And then in the hospital, you look at many proprietary devices in that field. So the ECGs, pulmonary function, Holter stress testing devices, etc., they have different interfaces. There is not a common standard. For some time there was a SCP standard, kind of a standard. Some companies did it, some companies didn't, and SCP and SCP was different. Then XML was used a lot of time and still is used a lot of time. Of course, has its value, and the same is true for DICOM. Raw ECG DICOM comes from the picture side and has been adapted as well for the ECG by some companies, but not by all. And then you have many different vendors. So, and still, when one vendor with the ECG devices, let's say, standardize on a specific interfacing protocol, I mean, you will have differences to the other vendors and so on. And typically in a hospital, you do not purchase everything from one vendor. You have multiple vendors for the different modalities because you want to get the best of breed in all the different things. And that, with the implementation, of course, you have to be aware of the security concerns which are in the hospital. If everything is communicating in the hospital with patient data back and forth, it needs to be in a secure manner. And you want to avoid any lost and delayed results. I mean, even an electronic solution, if the patient information is not accurately recorded, it may end up in a lost result. It's not a lost paper, it's then a lost digital report because it's somewhere in the database, but not assigned to a correct patient. So then that patient does not have his previous records. So a proper implementation needs to be done in order to get all the best out of that. So lost and delayed results, as well as lost billing opportunities for the hospital, and that's money already. And then, of course, direct device integration into the EMR, because you want to record all your results and examinations into the patient electronic record. And of course, doing that for all the different vendors, devices, modalities, I mean, that's a lot of different interfaces, and that's money. Yeah, and then if it's done not in a proper way, clinicians often have to deal with non-diagnostic image quality, or ECG coming from one company looking totally different than ECG coming from another company. And also, again, in the previous presentation, I mean, that was already nicely described what the effect of wrong setting in the devices can be for to mislead a physician when he's not looking carefully at the settings, which are as well on the paper. He might be misleaded and drawing the wrong conclusion. And to avoid all that, I mean, a proper implementation needs to be done. So I jump now into how does a paper-based workflow look like. And I mean, that picture looks horrible, and you see that many manual steps which are done. So and that's, I mean, that's not made up. That's really the praxis in some of the still paper-based hospitals. So say still the physician orders an ECG for that patient, that's performed, copy is made, that copy is put into the chart. Someone has to pull the previous ECGs from the paper archive, make a copy so that the doctor has both to be able to write on. Then the physician reads the ECG, does the diagnosis in a relatively quick time, most likely. Then he handwrites or dictates his interpretation, and that needs to be then transcribed, put into the chart, into documentation, and then typically at the end that is scanned again to put that in for the long-term storage back into the hospital EMR, the electronic medical record. So that looks complicated and is complicated, is time-consuming, and is error-prone. So whenever humans are doing a copy and having to pull out something and putting notes on something, there is always the mistake that something is lost, is changed, etc. After implementation of ECG data management, let's look at an example basing that on an order workflow. So an order for an ECG is generated in the hospital information system, or EMR. That order is transmitted to the ECG data management system. Typically that's done via HL7 message. So I call this now is transmitted to the ECG server. And then a cardiograph is used. The ECG is performed by an ECG technician. He has to identify the patient on the cardiograph. That ECG then goes back into the ECG server, and there it's automatically associated with the order, and it's assigned, and assignment happens based on patient ID, patient name, or order number, stuff like that. So, and with that, all the previous ECGs and studies are available as well for that patient. And when the physician does his interpretation, or the cardiologist does his interpretation, he has access to the previous ECGs, and he does his edits and confirms finally the ECG. And with that confirmation, typically then final transmission is from the ECG data management to the hospital information system, or EMR, is done again typically via HL7 with standard result messaging and also billing messages. Workflow can as well be assisted to be able to email or text the referring physician so that he knows the cardiologist now overread the ECG and the diagnosis is in his inbox, or other automated workflow possibilities according to the hospital's protocol and hospital need. And as Dr. Naim pointed out, that ECG a copy is transferred into the hospital HIS and EMR system. The original raw data still remains in the ECG data management system. Good, there are now more and providing as well modality work lists in their devices. So in the devices like an ECG machine, a cardiograph, stress testing device, a pulmonary function or whatever, a Holter device, they are able to receive work lists. And what is a modality work list? A modality work list is that the demographics is going already to the device. Of course, in a secure bidirectional communication of demographics between ECG data management system and devices it takes the results from. Another picture of that, I mean, ADT information is coming to the ECG servers, orders are coming to the ECG server, then modality work lists are created, which are available for the various devices. When the examination is done, ECG is going back to the ECG server. When the overreading is done, result and billing goes back into the hospital EHR. And EHR can stand for any other system, including vendor neutral, archive, or whatever. Good. So because we looked in more detail already how that workflow is going forward, I shortened here the picture and pointed out what is the difference. The difference in that picture to the previous one where we went through that workflow is that now instead of entering some information on the cardiograph, a work list was uploaded or pulled by the cardiograph, and the ECG technician simply has to select that patient from that list, and then that study is going into the ECG data management system, and the physician has immediately all the previous results and information available in order to do his diagnostic work. And the result again triggered on the confirm going to other systems. So that was very quick on that. But now, I mean, one word to that. ECGs are ordered in the US basically. Let's say in the US, typically every ECG is ordered with an electronic order. If we look at EMEA, many hospitals do not order ECGs. They are not used to order ECGs. They order an MRI, they order a stress test, but they do not order an ECG because of the sheer amount of ECGs they are doing. But there are then other solutions available in order to still get that ECG reliably to the correct patient. And look at that. Let's look at that together in more detail again. So in the hospital EMR, one of the systems is available for all the demographic data for all the patients in the hospital. And so there is an ADT stream, and ADT stands for admission, discharge, and transfer data. So it's basically the demographic data for all the patients which are ever coming to that hospital and have been to that hospital. So that ADT data is maintained by a master system, including name changes, for example, as well. So if a woman before marriage get ECG and results done and comes back later after marriage, of course, the ADT message will communicate that name change of that woman to all the other systems as well. Beside a patient ID, typically, which never changes, there will be temporary visit IDs for the people coming back. So when I come back to a hospital where I was a year before, I will have a different visit ID, but probably the same patient ID than before, and so on. So all of that, I mean, is managed with the ADT data, and of course the ECG server, which we can say have to know all that patient. So he has the patient demographic of all the ECGs he ever received, plus the ADT messages of all the patients who potentially at some point of time will get an ECG done. And with that information, then when an ECG is performed on a cardiograph and comes in again to the ECG management solution, I mean, configured there is configured basically at what data points to look at in order to automatically assign that study to the correct patient and have it then associated with all his previous study. Then again, the story keeps the same. Physician looks at the ECG together with all the previous information found by the system and pulled together for him on the screen. And when he, after editing, confirms the ECG, then basically all that information goes to all the other systems connected. As there is, I mean, one piece here, the ADT information is in the ECG data management system. Then, of course, somebody needs to enter some basic information for the patient before doing that ECG. It might be a visit ID or last name and birth date. The more information, the more accurate the association to the correct patient can be done. And because there is some manual stuff, of course, there is again a solution for that. All the devices basically many years ago already, and today, of course, can be connected with barcode readers or magnet card readers. So with that, of course, that solution is as robust as an order workflow, because the ECG technician simply scans the barcode of that patient. That barcode comes maybe with a paper, traveling with the patient through the hospital and the different departments, or he might even have a wristband, so it cannot be misplaced. And with the ID number populated in the patient ID field, everything will match exactly to the correct patient. Good. And whatever you have electronic, I mean, when you receive information electronically, you can have rules like if, then, else, and apply to that. And just showing here one example pointed out. So ECG comes in, the ECG server looks at patient age and decides then, oh, I have a rule that if an ECG comes in from a kit, I should send it to the pediatric physician's inbox. I can send as well an email notification that he knows there are ECGs waiting for his diagnosis, and then he goes into his inbox, and once he is done with the diagnostic, looking at ECGs together with the previous and all the other information, the result is sent to the EMR, and email notification goes back to the referring physician, etc., etc. And that's just one example. Another example of those configurable workflows are if ECG is coming from an ambulance into the hospital. Then, of course, that ambulance ECG is an emergency ECG. That can be routed already to personnel, to doctors in charge in the cath lab. They look at it and they decide if they should be prepared when the patient comes in, or if it's less stressful, etc. So, I mean, that supports all those goals which the hospital and the regions have to minimize the door to balloon time, so to speak. When an emergency happens somewhere and the patient gets picked up, he's treated already in the ambulance, that changes already his ECG. So those previous ECGs are important, and they should be together with the patient then in the hospital, available for the cardiologist, for the physician to look at. Example like that. But there are departments like the emergency department. Because when I first talked about ADT information, knowing about all the ECG server knows all the patients, I mean, there is one exception. I mean, if the patient is coming to the emergency department, he might not be known to the hospital already, and the emergency department personnel might find that a patient might not be able to speak up, so you cannot ask what's your name, what's your birth date. So you still have to take that ECG, of course, and start your diagnosis and treatment. And but then a proper ECG management solution should be able to support you with that in order to not make the life of the physicians more difficult than needed. So the emergency department can have special barcodes prepared for those emergency cases, always a set of that. And then that is assigned to that patient temporarily, and that ECG is done, is available for the diagnosis, everything in a preliminary inbox. And when the doctor has done his final interpretation, it's marked as read. And when then later an order is submitted for that patient and the ADT data is available, I mean, then that physician does not have to look back at that ECG again. It will go directly back into the EMR and follow the other workflow. Good. And now you saw already an ECG, and I mean, you have been familiar already now with that presentation. I mean, Dr. Naim showed different of those ECGs. Most of them which he showed had, beside those lead presentations as well, rhythm strips belong. Rhythm strips, I don't have an example here in that right now, would show you the full 10 seconds of the ECG in one lead to give you a proper thing. And what you see here, I mean, all the same with the ECGs, most likely similar with all the different vendors. You have the demographics on top, you have timestamps on top, then you have a measurement table where the QRS complex is measured, and it's not the measurement of a single QRS complex, it's averaged over the whole 10 seconds of the ECG which has been acquired. The same is true for the interpretation statements which are coming from the 12-lead algorithm. They are based as well. The algorithm looks at the complete 10 seconds of the ECG, and when I say 10 seconds, you can see here already when you count the beats. Here you see 25 millimeters per second, and if you count the millimeters, you will find out that you have only 2.5 seconds shown of each lead out of the 10 seconds which are making up a complete system. So if ECGs are just going without an ECG management system into a PAC system, then it comes like the cardiograph was configured with the filter settings and everything, with the gain settings, everything like it was configured and that, and it's not changeable because it's like a paper. It's not changeable. It's a PDF. A PDF is nothing like an electronic paper. And if it's encapsulated DICOM, be aware, an encapsulated DICOM is just a simple PDF in a DICOM wrapper, and the DICOM wrapper might provide me with additional information like the demographics of the patient to quickly assign it to the correct patient, but it does not allow me to change the waveform, the ECG. Looking at a complete ECG, I show you here with the blue circles what has been on the previous report. That's only shown on that report. The rest of the seconds of the full 10 seconds are not shown on a paper report, but it's available in the ECG data management system. So for later research or for some of the ECGs, a physician might go into more details. Then all that information is there, and with a mouse click he can access it. Then there is, beside report format, where there are different report formats, and there is always a preference for specific report formats, and the report format typically then is configured hospital-wide the same. And so the ECG management standardize everything already, the gain setting, the filter setting, the report format. And so all the different ECGs coming from the different machines from different vendors look the same to the physician and are the same to the physician. Do not just look the same, they are the same. Because another thing is filtering. Filtering is something which of course is looking similar between the different manufacturers, but still the implementation of a digital filter is up to the engineers of the company, and they typically don't disclose the full details of what they are doing. And so the effectiveness of the filter of different companies might be slightly different. So you should have apply a common filter to the ECG management in order to have comparable, let's say, view to the ECG. And I start with the first filter. It's a low-pass filter. Low-pass stands for that everything which is below that low-pass filter, everything which is below that filter setting will pass and will be shown as an ECG. Everything which is a higher frequency will be removed. And so you can imagine that, of course, a setting like 150 Hertz is what we would maybe start with, or maybe going to 100. 100 or 150 Hertz is considered the diagnostic filter setting for the low-pass filter. 40 Hertz setting you would use only in cases, in rare cases, and when you use it, you have to be aware that you reduce already and remove information from the ECG. Notch filter is something very clear. So your AC in the country has a specific setting. So we typically use the 50 Hertz. In the US, it's the 60 Hertz notch filter, and that removes the noise which are coming from, let's say, if a power cord is close to the patient, or other machines are next to the cardiograph, or the cardiograph itself has creates some noise. And that, of course, everything is amplified with bad skin preparation and bad electrodes, dry electrodes maybe. Then those electrodes and lines are picking up noise more likely. So they are acting then a little bit like antenna. And so notch filter is very safe to apply because it will remove exactly the 50 Hertz from the signal in order to give you the proper raw signal. Good, then is an artifact filter possible? Artifact shortly can make studies with looking cleaner. Left-hand side, still a good ECG to interpret, but on the right-hand side, of course, the line is a little bit thinner. It's a little bit easier for the eyes to look at, but it can as well reduce information, especially peaks that are very tall or narrow. And think of modern pacemakers. So pacemakers might be something which an artifact filter easily can filter out. Then there is a wonder filter. In the ideal world, I mean, the patient is not moving and holds very still, but there are conditions where the patient maybe cannot control his muscle movement very well. Look at Parkinson patients and stuff like that. So there might be then some reasons where you might want to put a wonder filter on if it's too heavy, but still typically the cardiologist physicians with a proper skin preparation, etc., are able to work without a wonder filter. But if it's available, be aware if it's switched on or switched off, because it has the effect on the ECG. A regular filter which always is used is then the high pass filter. Different to the low pass filter, the high pass filter let everything pass which is higher in frequency than the setting, and so you start with a very low filter setting like 0.05. So every signal below that will be removed, and everything in higher frequency then will be allowed to be shown on the ECG. Good. And here again, research indicates that a setting of 0.5 can affect the T waves and can lead to improper diagnosis. Therefore, the recommendation is to stick with 0.05 or 0.15. So start with 0.05. You're on the safe side. You can then, yeah, always go higher. So effect of different filter settings. Upper example is a nice perfect filter implementation applied to a good quality ECG. So the filter setting is 0.05 to 150 Hertz. So everything in the signal between those two values are going through and forming that ECG signal. And the lower portion, I mean, is, let's say, what we would call a non-diagnostic filter setting, but still, I mean, ECG looks nicely. And be aware that the filter implementation of different companies can be different. I mean, that's a nice example, and a lot of information is still there. But if you look here at the ST segment here, you see that deviation. I mean, here it's flat. So it's hard to see the deviation here. I mean, I assume Dr. Naim would catch from that signal the full diagnosis, but I mean, some people might overlook it, especially at nighttime and etc. Yeah, so with filter settings, in a summary, always keep in mind filters are removing signal. It's safe to use the high-pass filter and the low-pass filter with its diagnostic settings. Notch filter, also a very safe filter. My recommendation would be to keep it on. Artifact and wander filter, I would switch off and use only in rare, let's say, if needed. Then different gain settings. In the previous picture as well, you see here nicely those Cal pulses. They are always 1 millivolt. So when an ECG is shown on the screen or on a paper, it always should be presented together with calibration pulses, and the calibration pulses always show you the size, how big 1 millivolt on that paper or on the screen will be. You see the upper ECG is with the standard setting, which I would recommend as well. It's the 10 millimeter per millivolt setting. And because the chest leads are overlapping very much here on the screen, somebody here changed then the chest leads to half. So the typical settings are 5, 10, or 20 millimeter per millivolt. You would keep it on 10 millimeters per millivolt, and the cardiologist or physician might temporarily switch the setting in order to enlarge or decrease the signal in order to do some measurements, but then it will go back to normal again. And the possibility to treat the chest leads differently from the rest, I mean, is a nice feature in a ECG data management system as well. When I talk about diagnostic tools, of course, you want, maybe in some cases, you want to measure the ECG. Of course, you could count the millimeters here because you know the 25 millimeter per second. But I mean, still, you can adjust the caliper. And here I measure between the R to R. It's exactly 1105.3 milliseconds, which reflects 54.3 beats per minute. And what you can see in the lower picture here are those lines. So whenever you use a caliper, I mean, it's a nice feature to repeat that caliper over the whole page, so you see the regularity or irregularity of the ECG. And if you look at all of that, I mean, when you do calipers and you do ST measurements, of course, I would expect as well that the ECG management system is able to provide you with the Basset, Federica, or exponential ST calculations. Because, yeah, why not use it if a computer has the information? I mean, it can simply give you all those different things. Then the ECGs are coming in with interpretation, and of course, then a simple thing for a computer to do is to look at those interpretations and provide a serial comparison to the previous ECG. Looking here at the later one compared to the previous one, sinus rhythm no longer present, sinus arrhythmia no longer present, all those different statements are there. As well, what is new? There's now a ventricular pacemaker with that same patient. As you see, that ECG management color codes it, because as I mentioned already, or maybe I didn't mention, pacemakers, new pacemakers are so advanced compared to the previous old technology. I mean, those spikes are so small, they are so short in time, so are providing and working so efficient because of the sensing and the application of the electrodes within the heart. I mean, they, yeah, it's a very tiny signal, very good for the patient, bad for an algorithm to detect. So it's good to have to mark it in color, because you would most likely maybe overlook some of those pulses most likely. Good. Diagnostic tools, critical alerts. When in serial comparison already, the ECG data management looked at interpretation between different ECGs. Now the critical alert goes one step beyond. I mean, it searches within the critical statements for so-called critical statements, which are then defined. And then calls them out with a critical alert. And the idea of that is to draw the attention of the clinical personnel immediately to those ECGs if they are coming in with critical statements. So pull them up in the list to the top, color codes them in order that you see them, that it draws the attention to. And I compare it a little bit to all those tools. When we say diagnostic tools in the ECG data management system, I compare it to assistant systems when driving by the car. I mean, you did your driver's license and the driving school without assistant system, I assume, and for a good reason. They are switched off when people are trained for driving. But in the day-to-day use, when I go on the Autobahn, I mean, I'm more relaxed if I know that my car has some assistant driving systems in place, which would alert me when the car in front of me is doing an emergency brake. I mean, my car would follow that emergency brake and not bumping into it because I was on the phone or discussing with my family in the car. Okay, so use the computer where they are good with. I mean, with repetitive tasks, they will always give you the same result. As I said, we look now a lot at the ECG. How about other diagnostic devices in the hospital? If you have an ECG system in place, I mean, why not using the same technology and the same workflow capabilities for all the others, like stress event holder, patient monitoring, pulmonary function, defib, etc. That are all sources where ECGs can come from or coming from. And then, of course, you can make that round bigger, looking at all the different other results as well. And so all of that can go into such an ECG server, for example, and can then be available for in the hospital for the treatment, or even if the doctor during weekend is at home, he could look at that. I mean, all the results can be distributed with a messenger to different things, and smart devices, for example, can be used to look at the data. And then, of course, that ECG server communicates with the other systems in the hospital in terms of receiving the ADT messages, orders, sending out results and billing messages, can receive inbound HL7 or as well connect and integrate via web API into other solutions, so that the people, the clinical stuff in the hospital can work in their system. Like if somebody works in the PACS system and a new ECG comes in, it will be accessed from the PACS system like the ECG would be in the PACS system. So because the icon would show up, you click on that icon, and then for that patient you are just in focus. I mean, a web API call to the ECG server would bring that ECG onto the screen of that PACS system where the doctor sits. Interfacing costs. When you want to integrate all your different devices into your hospital information system, into your EMR or vendor neutral archive, those vendors will tell you what the cost of one interface will be. And so you can then use n amount of the interfaces you need times the money, and you will get the cost. And remember, cardiographs, I mean, if you have different vendors of cardiographs, for each vendor you might have your own interface because they have different interfaces, so different implementation. So what can save you money is if you have an ECG server, all of those devices are going and talking with the ECG server, and then you have only one one bill from the hospital information system provider for integrating the ECG server into that solution, instead of multiple amounts of money for that. And that's just sample. I mean, in some cases it's less, in some cases it's even beyond what those companies charge for implementing different modalities and device interfaces into their solutions. What are part of an ECG data management system? So, of course, there's a database. Database is important, and I pointed out because it should be an SQL database because you want to run reports on the data which you have. I mean, what Dr. Naim described is I could do a query on an ECG data management system, give me all the patients with a certain criteria, and then I can look at all the details of those ECGs, and I see the other results or other treatments of that patient, and I can do some research and get conclusions of that. Then, of course, ECG server needs all the device interfaces for all the different devices which you have already in the hospital or which you plan to use in the hospital. Users are working with it, so you need a user access management. Not everybody can see everything, and not everybody can change or edit everything. So there needs to be roles and responsibilities. Like you have it in the hospital, I mean, you need to reflect and have that in the hospital as well. And then you want to measure that. So you have an audit trail in place. Who looked at what, who changed what, at what time and date, and where did he dial in from, what IP address was it, etc. HL7 broker for the communication with all the different other systems or devices. System-to-system interfaces as well, like Active Directory, for example, because you need to hook up the ECG server as well to the Active Directory in order to have proper user identification and authentication. Web API, of course, for better integration into other systems, and therefore, of course, ideally it runs on a web server. Web server not necessarily meaning that you can go to the public internet. It would, when I talk about a web server, I mainly talk about a web server running within the hospital digital network. So several other server requirements, and that's not complete, that list on the left-hand side, just pointing out some major things. That ECG server should go onto the regular hospital IT infrastructure. You do not want to change everything around just because you want to install an ECG server. And I would recommend as well to have a separate test and production environment. Reason for that is in today's world, I mean, hospitals are target for hackers, and so frequent security patches and stuff like that, as you learn about the things need to be applied for those for all every system in a hospital. And so you would first apply it to a test system, of course, and then you roll it out to a production environment as well. You have all those different devices, and you might add new devices over the time, new interfaces to it. You would always start on test, so not affecting the production environment at all, and then after testing put it on production and so on. Then, of course, I mean, the ECG server is one thing. In order to work with it, I mean, the people in the hospital need to have a client, a viewer, to look at the data and to work with that. And viewer requirements are, you want to have zero footprint, so not any patient details left on that computer after the doctor logs off. You want to have thin clients, cost-effective, and also easier to manage and control for security reasons. And so, but on the other side, you potentially want to have it installed on each workstation in the hospital, even on mobile devices. So you see the list here becomes challenging, and installation should be done without any admin rights of a user. So not rolled out that somebody, then the IT department needs to roll it out. So, and ease of use is important. And so you might say, looking at that, it's nearly impossible with a solution. But of course, we mentioned on the left-hand side already web server. And so that's already pointing to the solution. And here is just on the screen how such a web-based ECG server client solution could look like. In the upper part, you see the current ECG. In the lower part, you see the previous ECG automatically pulled up when the doctor looks at the current ECG for his interpretation. All the previous ECGs, not just the one, most previous one, are available here in those tabs. And then in that user interface, I mean, on that side is the interpretation can be used for changing the interpretation, for pulling up statements and stuff like that, or looking at interpretation changes done to previous ECGs by whom, and as well giving access to all the other modalities, whatever is stored in that ECG server in that hospital. And so it should support as well individual physician preferences, so that he finds his statements quickly, can quickly edit and change the interpretation, most of it in a standardized way, and he can have favorites to do that, and also available free text for him. Good. Then, I mean, it should offer calipers, measurement tools, side-by-side comparison, and serial comparison, and as well tracking everything, activity in the system, and giving access to that in a way which is not just for the IT specialists, but as well for department leaders or clinical leaders, in order to be able to see who changed what in the system. Then typical IT requirements, when we talk to the different hospitals, they want to have a good 24/7, 365 remote support. Check on that if it's available really then in your country. It needs to be, as I said on an earlier slide already, compatible with your existing IT infrastructure. Active Directory support, very important. And it should give you, and the 24/7 support should include regular remote software, regular software upgrades. HL7 broker should be part of it, and the solution, I mean, should be installable on hardware or on software, but of course the solution should support all the different virtual servers, especially the ones which are in place already in your hospital. Web API for proper integration into other systems, single sign-on experience. So when Web API is used because you are working in the PACS system, you look at the ECG, the Web API calls up a web browser window, and you then can do your work in the ECG server system. And that you, of course, you do not want to sign on again. I mean, you want to have that single sign-on experience, that you are logged into it already, that the ECG data management knows your patient in focus, gives you immediately access at this latest ECG and all his previous results, and you do not have to log in. And of course, the IT wants to have it compatible with the storage solutions they invested in, or the existing backup solutions they have, and with the virus protection in place for the hospital. All of that, I mean, is needed. And we are talking here about medical products, not about the IT system like other things. So ECG data management typically as well is a medical product like the devices, and so is under that control. In a wrap-up and summary here a little bit, what are the different requirements, again listed. So you would look at what is the ECG management solution in terms of multiple vendors? What do they support? What are the modalities they support? Think about ease of use, because your hospital needs to be trained on using that system. So look at a simple user interface, intuitive to use. Be sure that that company provides you with regular security updates. And I remind again that for that, I would recommend always a test and a production environment. That it's able to support all your workflow needs, that it comes on thin client with zero footprint, most likely web-based, so at least without any plugin, etc. So web-based, of course, does not mean there's no plugin. Some of the web-based system might use Java and stuff like that, which is not good. Your IT department will not like that Java is enabled on all the hospital. So web-based, just based on HTML5, for example, but no plugins. Web-based as well for all the different user roles, including administrators for the database. So, and of course, all the clinician work, including editing, not just viewing, should be done web-based. Mobile devices should be supported. I mean, you would say when it's web-based, it's already on every mobile device. Yes and no. Mobile device operation is somehow different. You don't have a keyboard, you don't have a mouse, you have a touch screen and different ways to work with it. So look at that, that it's really then supporting that in order to, if you use mobile devices, that it's a good user experience. Active Directory, I talked already several times about that. I just repeat it here. You should have configurable reporting. Everything is tracked in the database. Of course, you want to be able to query that database, and ideally you do it as well in the web browser, and do you call up a different tool for it. Audit trail as well, ideally available through the web GUI, graphical user interface. GUI stands for graphical user interface. So not logging on as a system administrator to the server in order to get log files and stuff like that. Audit trail should be part of a web GUI. Additional requirements, I mean, hospital might look at teaching features. That's a clinical feature. So teaching features are things like suppressing maybe the interpretation and all the automated tools temporarily, so that assistant doctors during learning are forced to really interpret the ECG. And then, of course, later a physician would look, or a cardiologist would look over it, and that would provide feedback for the assistant doctor. On-site training should be included when it's rolled out into your hospital, so that you have all that support of the company for the training and answering all the questions of the users. More support and lifecycle cost of such a solution. I mean, is a 24/7 365 support available, and at what cost? Are security patches included in that cost? is software renewal included in that cost? The difference between security patches and software renewal is security patches are to the current software version in order to, whenever something is discovered, which is a potential, let's say, hole, because the hackers are never standing still. They are learning new techniques. And then, of course, at the same time, our engineers or the engineers of that solution have to continuously look at whatever they coded to make it secure with patches. That's patches to the current version, but there might be software renewal because Windows is changing an operating system from Windows 2008 to 2012, which happened already, and now further on. And that might need some software renewal of the version installed. All of that should be included, of course, in a 24/7 support, ideally. Good. With all of that in mind, I mean, I would recommend now for you that start your own planning if you are in charge in the hospital, or look at what's in your hospital. What are the existing devices, new devices you want to connect? What are the workflow challenges you have in the hospital in order to, I mean, avoid those? I mean, and as well, what do you want to measure in the hospital? But because if you want to improve something, you first have to measure. You need a baseline. And only from that baseline you can improve. And for that, you need to measure, and you need to continuously measure in the same way in order to see the improvement. My recommendation, start in steps, small steps, create a roadmap starting with ECG, add more and more modalities and functionality over the time. And if you are in the process of looking into those, reach out for demos to the various vendors on the market in order to build your to get a complete picture of that. Good. With that, I'm at the end of my session. I'm open now basically for the wrap-up. I see just that typo here. Good. I'm open, awaiting your questions.
Thank you very much, Mr. Thomas, for this presentation and very informative knowledge that you provide. Now the audience can just send the questions, and Mr. Thomas, he will answer it. Mr. Thomas, already I assigned many questions to you during the presentation, so you can start answering and read these questions.
Yeah, I'm just searching for, let me see. Fine, yeah. Okay. Let me scroll around a little bit.
Okay.
Okay, yeah, it's many indeed. Because I looked only at a small line.
Yeah, I'm keeping sending you. Yes.
The first one is a very quick one. What is the difference between a normal ECG and a treadmill test? I mean, on a treadmill test, typically the ECG is continuously recorded, but then 12-lead ECGs are done on each stage. A treadmill test goes in stages. That means, and stage means the treadmill slope and speed is increased over time, and at each stage ECG is done. And so you see the reaction of that patient's ECG basically based on the stress he is undergoing. And typically there you look at the patient heart rate, and at a specific heart rate increasement, etc. You would end that thing. Privacy issue in archiving ECG. Is the biomedical engineer responsible? I mean, that's a shared thing between the IT and mainly the IT and the company providing that in planning. For this, Is medical engineer responsible for this type of device to fix it and this stuff? No. I mean, you need a 24/7 support in order to manage an IT solution like that. The biomedical responsibility would be to take the call from a user saying, I don't see that ECG. And of course, the biomedical engineer would receive an administrator training and mean that he has the full access rights to the system from a technical point of view to be able to validate the question of the user and then point it and route it to the company providing the solution. So that would be my take of that. I mean, if it's a real system implemented, of course, if you implement bits and pieces from different vendors, I mean, the hospital might end up being responsible for those bits and pieces because, but if you go for an overall solution like I described in the last slides, I mean, that's then basically just a question to those providers of that. Archiving system, is it just for ECG? No. Archiving system, I mean, for ECGs should be I mean, the thing for the ECG is because of the special needs of the ECG, looking at the previous and stuff like that, it's treated a little bit different from other archiving systems. Other archiving systems then are maybe a vendor-neutral archive where you put all that results for a real long-term storage, and that's the main reason then that you are able to pull it up if there is maybe a legal question. If let's say there's a labor and delivery and all that data is stored in an archive system, and then that former, let's say that person turns into a patient in a hospital, and I mean, there's a legal case where something wrong with labor and delivery. I mean, then you need to be able 20, 30 years later in time to pull up those records in order to prove that everything what was done in the hospital was correct. Can we connect ECG devices with the HIS? I mean, yes, I mean, some possibilities, and then comes to what I pointed out. If it's an encapsulated DICOM or a PDF, it's not diagnostic anymore. It's just a picture stored in the HIS. And do you automatically get all the previous and stuff like that? No. Do you have all the measurement tools and diagnostic tools? No. Please again, the full name for ADT. ADT stands for admission, discharge, and transfer. So it's HL7 protocol of the demographic data, which are created at admitting a patient. They are changed at discharging a patient and transferring a patient. So the ADT message knows as well in which department that patient currently is, if he is in hospital or out of hospital, what are the different visit numbers and visits he had in the previous time. All of that, I mean, is managed by those things. What is door to balloon? Okay, that was a very acronym which I used. So when the patient arrives at the hospital door or in the ambulance and critical ECG is diagnosed, which requires a cath lab, and in the cath lab, I mean, a balloon might be placed into the heart and the stent is placed and stuff like that. That's the acronym. Then how long does it take when the patient comes and shows symptoms? How long does it take the hospital to have him in the cath lab and the treatment? That's door to balloon. The question is, if I think in the future artificial intelligence will have an influence on the ECG reading, I think, of course. Even today already, I mean, 12-lead ECGs are one of the species which are best researched already and standardized, as Dr. Naim was describing as well. And that will not end where it is now. So 12-lead interpretation algorithms today are already very accurate. With artificial intelligence, there might be even more coming to us. Currently, such an Apple Watch, records 1 lead. Over the time, devices will pick up other signals as well in an elegant way, and with the artificial intelligence behind, it will give you some proper, let's say, triage or alerting. A question comes to me, let's suppose each different. There comes a question. Let's suppose each person has a different ECG signal. How should create a baseline from that? Okay, that really has been done over many ECGs, over big databases, and with that is a baseline created. But as Dr. Naim pointed out as well, there are other things the doctor looks at as well. So is the person sweating? Is he an athlete? Etc. Question if such an ECG server should go to a hospital or go to a certain city and stuff like that. That's a decision of the community. Those ECG solutions which I know of, which are on the market, are able to have multiple hospitals connected together, of course. Can act maybe one ECG server for a hospital chain. Who can work on ECG? I'm health informatics specialist. Can I work on this ECG? Probably not. You need the doctor for the diagnosis. You have a trained ECG technician to have a proper skin preparation and all of that to get a proper 12-lead ECG. Not all ECG devices have an access to be connected to the HIS. That's correct. So when purchasing devices, be aware that you look up the capabilities to connect them. And be aware that the capability should include to get the raw data from that device into such a system and not just a PDF or a picture. What about that? Programmer analysis can be included in ECG management systems, yes or no? Yes, that's what we do. We connect with, or there are companies which do that, which are specialized on that, and those systems can be put together to one system. What is related between EHR and ECG? In my presentation, I had different words sometimes for the same, but EHR and ECG are two different things. The ECG was what Dr. Naim was talking about already. EHR stands for Electronic Health Record. Other words are EMR, Electronic Medical Records, HIS, Hospital Information System, different names for a lot of different stuff. Question is, what is the next step for ECG in the future? Maybe taking an ECG without applying electrodes. People are working on solution like that. Maybe devices integrated into your clothes, etc., etc. The ambulance car, how can it connect to the system? The ambulance car has electronic connection to the hospital already. Most of the solutions provide solutions like that, so that from the hospital 12-lead ECG can be transferred into the hospital already. ECG, if it can connect to the HIS or PACS wirelessly. I mean, yes, I mean, wireless or LAN connection, in fact, is more or less the same. It's just, yeah, it's just a different way. So at the end, for the systems, it's a LAN connection. If it's wireless or not, I mean, it's just a connection. There are questions repeatedly which I ignore. What are the best solutions? I mean, because of having worked for some of the companies before and working for a different company now, of course, I don't answer and go into those questions. I leave that up when you ask for demonstrations with the different companies and vendors. I mean, you will find out, I assume, quickly. And I think with the questions and points I raised, I mean, I should have provided you with some good possibilities in order to ask proper questions to find out who is the best. Can you elaborate a little bit more on Active Directory support? Active Directory support is needed because people working in a hospital, there are many people, and the IT department would be totally busy of giving those people access to different solutions and to the hospital network and so on. And when somebody changes his position or leaves the hospital, I mean, by disabling that again, I mean, all of that is managed by Active Directory, by a central system, and all the other solutions in the hospital should query that Active Directory to be sure that that person still is a doctor in that hospital, and what is the responsibility of that doctor? Is he in charge of that department? Is he in charge of this and that, and etc. Good. I think I run through the majority of the questions.
Yes, thank you very much, Mr. Thomas. Actually, also many questions we received regarding the hands-out. For all audience, you can go to the tab of handouts, and you can download the both presentation for Dr. Naeem and also Mr. Thomas. So you can, it is available now. Actually, you can download it right now. Also, we received many questions regarding the certificates. Usually, the certificates, it's available in the society website in your account within 48 hours from now. I would like really to thank again Dr. Naeem Al-Shuaibi and also Mr. Thomas Lutz for the time they spent with us and the webinar and the presentation they provide. Thank you very much, Mr. Thomas. Thank you very much, Dr. Naeem. And I wish all the best for the next step.
Yeah, thank you everyone for attending that, and thank you Hatim as well for organizing it.
Thank you.
Feel free to contact me. Yeah, my contact details are now on the screen, and therefore as well later in the presentation you can as well connect with LinkedIn or send me an email. Happy to answer more questions later on. That's great.
That's great. Thank you very much. So we will close the webinar now. We will keep it just for 2 minutes so the audience can be able to download the handout. Thank you very much. Goodbye.
Thank you and have a good evening. Bye for now. Good night. Bye-bye.
في أسئلة بتيجينا حاليا. There is some questions we received regarding how you can download the recorded webinar. All the recorded webinars, it will be sent to you by email within 24 hours with the recorded link. For the presentations, you can download it from the tab of hands out. تقدروا تسووا داونلود للبرزنتيشن. في عندكم خانة اسمها هاند اوتس، فيها ملفين، فيها ملف للدكتور نعيم وملف لمستر توماس. شكرا جزيلا لحضوركم مرة ثانية. حننهي الآن الويبينار. فمان الله.